Mr. Chairman, ladies and gentlemen, first of all, I would like to thank SAGES for giving us an opportunity to present our data on the interim results of a prospective registry. These are my potential conflicts of interest. Electrical stimulation of the lower esophageal sphincter has been shown to be effective in animal and human studies. It leads to a measurable normalization of acid reflux through improvement of LES function. It is effective in the long term. Results for more than 4 years are available. It is safe in trials without causing dysphagia, and it is reversible. Data from routine clinical practice are still lacking, and therefore it's important to look at our experiences. These are data from 2 long-term published studies with 66 patients recruited from 11 centers. And as you can see on the left side, the esophageal acid exposures normalizes after the procedure, and this holds true for 4 years. The same was seen with the GERD-related, health-related quality of life, normalization after the procedure, and good results seen after 4 years. And this is our study protocol. The study is now active in Germany, Denmark, the Netherlands, Austria, Mexico, and Argentina. There are 13 active sites. Data are available from 166 patients, and we recruited 33 patients in our reflux center. We looked at safety, quality of life, physiological data as available, and the primary safety endpoint were adverse events observed in our patients. Secondary efficacy endpoints were the quality of life, measured by the higher QL, SF1-2, and the PSQI, and GI symptoms. We looked at PPI use and healthcare resource utilization. And these are the data available for the esophageal acid exposure. As you can see on the left side, these are all data, and on the right side, paired data were available, and you can see that there was a normalization of the pH exposure in the esophagus with a trend to better results after 12 months as compared to the 6 months data. The same was seen with the health-related quality of life. On the left hand, all data available, and on the right hand, the paired data, also normalization after 6 months with a trend to better results after 12 months. We also asked for regurgitation. 63.4% of the patient had a moderate to severe regurgitation at baseline before the procedure, and this figure drops to 22.5% after 6 months and improved to 13.4% after 12 months. We also asked for extraesophageal symptoms, recurrent cough, recurrent pneumonitis, and shortness of breath. And as you can see, there was a considerable improvement in these symptoms in the patients after 12 months compared to the baseline data. We also evaluated the sleep quality. 67% of the patients had abnormal sleep at baseline, and this normalizes after 6 months and 12 months. And again, these differences were significant. We asked for continuous PPI use and on-demand PPI use, and as you can see, the proportion of patients using PPIs drops considerably after 6 months and 12 months. 25 to 30% of the patients had at least some PPI use after the implantation of this device. Concerning safety, there was a reduced incidence of dysphagia and gas bloat after 12 months compared to the baseline data. There was 1 instance of mild postoperative dysphagia, which resolved without intervention, and there were 4 severe adverse events reported in 3 patients. 1 myocardial infarction-related sudden death at 11 months postoperatively, not related to device or procedure. 1 event of lead erosion detected during routine endoscopy. The device was removed during laparoscopic fundoplication, and there were 2 events of gastroparesis in 1 patient which resolved. So, I come to the conclusion. Electrical stimulation of the lower esophageal sphincter is safe and effective in routine clinical practice. The results are very similar to outcomes in clinical trials, with improvement of quality of life, elimination of or significant reduction in heartburn and regurgitation, improvement or normalization of esophageal acid exposure, and control of extraesophageal symptoms and sleep disturbances. Electrical stimulation is, in our view, a viable treatment option for well-selected GERD patients with bothersome symptoms and/or side effects from PPI or who wish to stop PPI therapy. Thank you for your attention.
Any questions? While somebody's coming up, where do you think this stands in with all the Nissen fundoplication that we can do there? You know, obviously PPI, then there are so many other strata, links, etc. available. Given all this, with your experience with this device, what do you think? Where do you think this will stand in the future in the next few years?
I think the best patients would be young patients without large hiatal hernias, otherwise you have to repair the hernia, and who did not wish to be treated with a PPI, who have response to PPI treatment, who have classical reflux symptoms. Some may have some extraesophageal symptoms, but this is, from my point of view, the core group which I would offer this device.
And how would you compare that, the same group, if they were, offered, say, a Nissen fundoplication versus this? If they are eligible for this device, what would you say would make you consider Nissen versus this?
I would prefer this device because this is less invasive, and if it fails, you can do the Nissen fundoplication after that. This would be an opportunity. Whether we can do first Nissen, and if this fails, this procedure will be subjected to another study. We don't know this, but this will be clarified in the future.
I think we've run out of time. Thank you very much.